My dear students, so thank you, and I again pray to Almighty God for your healthy life, and I wish you will continue your study in peaceful, healthy life. I again pray to God for you. And today we will discuss uh, some question on the GIT system. In the last class, we have discussed 5 questions about GIT and liver disease. Today, we will discuss another 5 questions from GIT and liver disease. Today, first question is name 4 systemic complications of acute pancreatitis. And the systemic complications of acute pancreatitis are septic shock. Second, diabetes mellitus. And diabetes mellitus occurs due to the damage of the beta cell of the pancreas, and hypocalcemia due to deposition of calcium in the fat. Hypoxia also occurs. There may be hypoalbuminemia due to increased vascular permeability of the protein. So these are the systemic complications of the acute pancreatitis. And our next question was 4 alarming features of IBS. Alarming features of IBS, if age is more than 50 years. Usually IBS occurs before 50 years, but if it occurs after 50 years, that is alarming. And hematocrasia, that means fresh blood per rectum. And weight loss, anemia, and family history of colonic cancer. So these are the alarming feature of the irritable bowel syndrome. If these things are present, then we should be alert that the patient may have some malignant disease or any other chronic disease other than IBS. Our next question was, tell 4 causes of acute gastritis. And the causes of acute gastritis are H. pylori and alcohol, NSAIDs, and smoking, which are the 4 causes of gastritis or gastric erosion in the stomach. Our next question is, a 18 years male presented with history of fever 5 days back and severe anorexia and vomiting. Blood test revealed serum bilirubin 2.9 milligram per deciliter and ALT is 1350. Next, what is your provisional diagnosis? What is your provisional diagnosis? Our provisional diagnosis is viral hepatitis. Viral hepatitis. And next question was, name the causative agents of the viral hepatitis. And the causative agents of acute viral hepatitis are hepatitis A virus, B virus, and E virus. Now, treatment plan for viral hepatitis. And general measures, high calorie diet if patient can take orally, and laxative to avoid constipation to prevent hepatic failure, and avoid hepatotoxic drug. So these are the general measures we usually follow and advise to the patient. A specific treatment, IV fluid. especially 5% dextrose aqua, and no antiviral drugs is advised in acute viral hepatitis. And monitoring patient serum bilirubin, HGPT, and prothrombin time, and to detect any complications, and if developed, and we should treat it. And this is the treatment. And some prophylactic treatment is maintain good sanitation to prevent hepatitis A and E virus, and immunoglobulin therapy for hepatitis B. Our next question is a 50 years old patient presented with chronic diarrhea, weight loss for 2 months. Patient is mildly anemic. Mention 4 possible GIT findings indicating nutritional deficiency. Mention possible general examination finding indicating nutritional deficiency. And the general examination finding in nutritional deficiency are anemia, alopecia, glossitis, angular stomatitis, leukonychia, non-pitting edema, and skin rough and scaly, loss of sensation in hands and feet due to vitamin B12 deficiency. For investigation of this patient, hemoglobin level may be reduced. Serum calcium also reduced due to decreased absorption of calcium. Serum albumin reduced in protein-losing enteropathy, and vitamin B12 level will be decreased due to delayed absorption in ileum. So these are the 4 investigations to detect nutritional deficiency in this patient. And tell 4 differential diagnoses of this malabsorption patient. One is chronic pancreatitis, second is abdominal tuberculosis, third is tropical sprue, and fourth is your non-Hodgkin's lymphoma. Now question number 9. A 40 years old man with hepatitis B induced cirrhosis was presented with increasing ascites, progressively weight loss, and right upper quadrant abdominal pain. What is your possible diagnosis? My possible diagnosis is cirrhosis of liver with hepatocellular carcinoma. Mention the clinical sign and investigation in favor of diagnosis. General examination on hepatic phases, jaundice, unconsciousness, edema, flapping tremor. All these general examination features may be present in case of patient with hepatocellular carcinoma with cirrhosis of liver. And other features of general examination are spider telangiectasia, gynecomastia, leukonychia also. Abdominal findings are liver enlarged tender with bruit present, ascites present, splenomegaly present. Regarding investigation of this patient, alpha-fetoprotein more than 4,000 microgram per ml suggests hepatocellular carcinoma. Serum bilirubin increased, ESR may be high. Ultrasonography of the whole abdomen, liver ecotecture increased, ascites present, splenomegaly present. Chest X-ray to detect metastasis to lungs. Viral marker HBs AG, HBEAG and HBC AG, CAG, IgG variety. CT guided or ultrasonic guided apnea of the liver will confirm the diagnosis. Now, last question of the GIT system and liver disease. A 30 years old male with 7 days fever, abdominal pain. On examination, the patient was ecteric. Mention the differential diagnosis. The differential diagnoses are cholangitis, cholangiocarcinoma, and cholelithiasis, cholelithiasis. What history and clinical examination will lead to your differential diagnosis? Fever, jaundice, and upper abdominal pain. Fever, jaundice, and upper abdominal pain suggest cholangitis. Pain in right hypochondrium, radiating to right shoulder in favor of cholelithiasis. Upper abdominal pain, fever, pruritus, dark urine indicates cholelithiasis. And upper abdominal pain, obstructive jaundice, weight loss indicates cholangiocarcinoma. Now on examination, deep jaundice indicates cholelithiasis and cholangiocarcinoma. Pale stool in favor of cholelithiasis and cholangiocarcinoma. Skin scratch also indicates obstructive jaundice. Lump in right hypochondriac region or epigastric region indicates cholangiocarcinoma. Now, for investigation of this patient, serum bilirubin markedly raised in obstructive jaundice due to cholelithiasis and cholangiocarcinoma. Ultrasonography of the hepatobiliary system shows stone in common bile duct in case of cholelithiasis and mass lesion in the common bile duct and pancreatic head in cholangiocarcinoma. And CT scan of the abdomen also detect cholelithiasis, cholangiocarcinoma, and carcinoma of the head of the pancreas. ERCP shows dilatation of the biliary tree due to obstructive jaundice due to cholangiocarcinoma and cholelithiasis. And CT guided apnea to confirm diagnosis of cholangiocarcinoma. So this is regarding the question over the GIT system and liver disease. And now we'll discuss some questions. So now we'll discuss regarding the question about the endocrine disease. Question number 1. A 35 years old man presented with palpitation, weight loss, chronic diarrhea, and excessive sweating. So what is your diagnosis? Our diagnosis is thyrotoxicosis. Next question, write down 2 important investigation, 3 complication of this disease. 2 investigation, serum T4 level will be increased and TSH level will be decreased. And 3 complications are atrial fibrillation, heart failure, and myopathy. And our next question, write down the principle of management of this patient. First, medical treatment. Indication of medical treatment: Graves' disease, age less than 40 years, and first time detected thyrotoxicosis. These two are the indication of medical treatment. And drugs in medical treatment are carbimazole, 5 milligram tablet, 3 times daily for 4 weeks. Then maintenance dose 20 milligram, 15 to 20 milligram daily for 18 months. Tablet profile: thyroxine 400 to 600 milligram per day and suitable for breastfeeding and pregnant patient. Tablet propranolol 40 milligram month of BD till heart rate normal. And regarding the surgical treatment, the mode of surgery is subtotal thyroidectomy, and indication of surgery are large goiter, recurrent thyrotoxicosis. And radioactive iodine therapy indication: age more than 45 years and relapsed thyrotoxicosis. Question number 2. A 50 years female presented with recent weight gain, hoarseness of voice, puffiness of face. On examination, his pulse rate was 50 beats per minute. What is your diagnosis? Diagnosis is hypothyroidism. What investigation do you suggest for this patient with interpretation? Investigations are TSH, which will be increased, T3 and T4 level will be decreased. ECG will show low voltage ECG, where RF is less than 5 mm in lead 2-3 ABF and less than 10 mm in B1 to B6. And treatment of this patient: tablet thyroxine 50 to 150 microgram daily, lifelong. What medical emergency may occur in this patient? The patient may develop myxedema coma, and it is characterized by decreased level of consciousness, elderly patient, body temperature 25 degrees centigrade or very low, and it is treated by injection triiodothyronine 20 microgram IV daily, followed by levothyroxine orally. Injection hydrocortisone 100 milligram IM 3 times daily, rewarming the body, IV fluid, IV broad spectrum antibiotics, and high flow oxygen. These are the treatment of myxedema coma. Now question number 3. A 40 years male admitted with the complaints of anorexia, nausea and vomiting for 15 days. On examination, he is emaciated, hyperpigmented, and BP is 80/60. So what is your diagnosis? Our diagnosis is Addison's disease. Next question, write down the important causes of this disease. And the causes are autoimmune cause, adrenal tuberculosis, and hemochromatosis, sudden withdrawal of corticosteroid therapy, and bilateral adrenectomy. Now, treatment of adrenal crisis. Injection hydrocortisone 100 milligram IV 6 hourly until patient can take orally, IV normal saline, IV broad spectrum antibiotics, IV 25% glucose to correct hypoglycemia. Hyperkalemia is corrected by IV volume, fluid volume replacement. Maintenance treatment of hydrocortisone. 10 milligram morning and 5 milligram evening. And what advice you will give to this patient? In case of febrile illness, the steroid dose should be double. For minor operation, injection hydrocortisone 100 milligram should be given. For major operation, injection hydrocortisone 100 milligram 6 hourly should be given. And this patient should also carry a steroid card all along. Question number 4. A 50 years diabetic male presented with sudden loss of consciousness. On examination, patient is sweaty, rapid bounding pulse, stable BP. What is your diagnosis? Diagnosis is hypoglycemic shock. Now name 4 risk factors of this condition. Elderly patient, longer period of diabetes, irregular intake of insulin, missing of meal, impaired awareness of hypoglycemia. Mention investigation and treatment of this patient. For investigation, serum glucose level less than 3.5 millimole, suggestive of hypoglycemia. And treatment is given by 25% dextrose, 100 ml IBS stat or injection glucagon, 1 milligram not 12 milligram, 1 milligram IM stat. And after recovery from the acute stress, hypoglycemic patient, oral glucose and sweets should be given. So this is the last question. And a 20 years non-diabetic male presented with sudden loss of consciousness. On examination, patient was febrile, pulse BP not detectable. What is your diagnosis? Our diagnosis is diabetic ketoacidosis. What other clinical and lab finding you suggest diagnosis? Symptom: polyuria, increased thirst, weight loss, nausea, vomiting, abdominal pain, blurred vision. And sign: dehydration, osmosis breathing, hypotension, tachycardia, cold extremity, confusion, coma. Lab finding: blood sugar more than 30 millimole per liter, invalid ketone body present, potassium may be decreased, bicarbonate also decreased. Now treatment. Injection insulin 50 units in 50 ml normal saline through insulin pump 6 units per hour, treat blood sugar 15 millimole. Then 3 units till blood sugar 10 millimole. Then 2 units till patient can take orally food. Normal saline, 1 liter normal saline should be infused within half an hour, next 1 liter within 1 hour, and next 1 hour within 2 hours. Then 5% dextrose aqua IV when blood sugar less than 10 millimole. For potassium therapy, no potassium therapy given when serum potassium more than 5 millimole. Injection KT 40 millimole, not ml, millimole when serum potassium 3.5 to 5.5 millimole. Additional injection KT when serum potassium level is less than 3.5. Injection sodium carb 7.5% IV slowly. Injection IV antibiotics and special general measures, catheterization, maintain intake output charts, monitor all vital signs. So this is the all 10 questions, 5 from the GIT system and 5 from the endocrine disease has been discussed. So I lastly again I pray to Almighty God for healthy and peaceful life of my students, and I wish they can read, they can continue their study and take preparation for next exam. And again, I hope for their healthy, peaceful life. Thank you all.